Okay, so one question that came up was, what is enterohepatic recirculation? That is essentially a process where a drug or a certain type of product can be absorbed from the GI tract, gets into systemic circulation, and then as part of its excretion pathway, gets excreted through the bile duct. So it'll get kicked back out into the GI tract from the bile duct, and then it's at the GI tract again where it can be reabsorbed. So it goes through this kind of cycling mechanism to where you get kind of an extension of the half-life or a longer duration of action than you would expect based on the actual half-life of the drug. So, for instance, like birth control does this, certain anti-epileptics do this, or seizure meds do this. So, yeah, so it's good to have an idea of that process and how that works.
So that pathway isn't specific to cholesterol?
So yeah, because I mean the bile, it's not specific to just to cholesterol. It certainly undergoes that, but other things do as well. Yep.
And my second question was, okay, so the LDL receptors are on the liver.
Mm-hmm.
The ApoB100 is a protein on the LDL itself.
Mm-hmm.
If you have the primary hyperlipidemia,
Yep.
do they affect the ApoB100 protein or the receptor?
My understanding was they affected the they actually affected the apolipoprotein on the LDL.
Okay.
That was my understanding, but I could be incorrect on that. You should double check. Is that wrong? Anyway, you can double check me on that, but that won't be a specific question on the test for my purposes at least. So, okay. Any other questions before we continue on? All right. So we're going to do our RAS inhibitors, which stands for, what does RAS stand for?
Angiotensin aldosterone.
Yeah, renin-angiotensin aldosterone system. There we go. All right. So we know we've kind of mentioned this before, especially when talking about our diuretics and talking about diuretic braking and things like that. We know that this system is responsible for helping with blood pressure regulation, helps with secretion of aldosterone. What does aldosterone do? Yeah, retain fluid and sodium, so it's helpful with that. Will affect renal blood flow, sodium excretion. We'll have a lot of other effects as well. And so we're going to look at drugs that specifically inhibit this pathway. So here you can see that can start off in the kidneys where renin is being released from the kidneys, usually in response to if it kind of senses a drop in pressure, if it needs to regulate more flow to the kidneys, it will end up releasing more renin, in which case you start off this pathway where you can see the conversion from angiotensin 1 over to angiotensin 2. And that's the critical step where one of our group of drugs are going to be working. So that's that angiotensin converting enzyme is the big enzyme there we're going to see. Notice as well that angiotensin converting enzyme is also responsible for metabolizing another product called bradykinin. That's going to be important for some of the side effects we're going to talk about with these drugs. From there, once angiotensin 2 is formed, it's able to affect the adrenal cortex, where it can release more aldosterone to stimulate fluid retention, and it can also work as a very potent vasoconstrictor to cause increase in blood pressure. So again, the rate of renin release by the kidneys is going to be controlled by that renin-baroreceptor, which is just a pressure receptor. So if it senses low pressure, it's going to release more renin. The macula densa and also the sympathetic nervous system as well will help to be controlled by this. So again, if you have decreased renal perfusion, you're going to end up getting increased renin release because those renal baroreceptors are not being stretched as much. And again, remember, over time, when you have hypertension, those baroreceptors get recalibrated so that over time, normally 120 over 80 is your normal blood pressure. Over time, those can be kind of resensitized to where 150 over 90 might be your new normal for the baroreceptors. And so if you have a drop from that, that's where you can see upticks in renin release. So just keep in mind that one of the goals here is to help to kind of reset those baroreceptors over time. The macula densa is going to respond to changes in sodium and chloride. So any decreases in that, especially if you were to have like loop diuretics or something on board, can help to stimulate release. And then the sympathetic nervous system, so the renal nerve activity can help control release of things like norepinephrine and epinephrine, and they're going to help to innervate these juxtaglomerular cells. And basically here what you see is that the beta-1 receptors can help to increase renin release when activated by these the sympathetic nervous system. So angiotensin 2, as we mentioned, is a byproduct of renin release. It's a vasoconstrictor, stimulates aldosterone secretion, will cause renal vasoconstriction. You guys remember if it was on the efferent arteriole or the afferent arteriole? The efferent arteriole, right? So coming out of the glomerulus. Yeah, afferent's going in, efferent's going out. So prostaglandins are important as a vasodilator for the afferent arteriole, but angiotensin 2 is important for constricting the efferent arteriole, and that's what's causing that back pressure that allows for that flow to occur through the nephrons. You'll also see that large amounts of angiotensin 2 will cause a negative feedback loop and actually inhibit further renin release. So there's some amount of homeostasis going on there. Yes?
Well, so is that how beta blockers work for blood pressure, is inhibiting that renin release? Or is it more on the heart?
No, it's more working directly on both the heart and also on just decreasing cardiac output to some degree and helping to just relieve some of that pressure there.
Okay.
Yeah. So we see angiotensin 2 helping to increase norepinephrine release. That's again working through that sympathetic nervous system. When you have it'll help to stimulate thirst and sodium appetite and whatnot, and then also stimulate the ADH secretion, which is that antidiuretic hormone. So again, you can see all these things working to increase blood pressure and fluid retention. And then the other big thing we have angiotensin 2 doing here as well is the cell tissue hypertrophy and cardiac remodeling after MI. And so this is going to be a big deal. And this is why our ACE inhibitors and our ARBs are going to be so important for patients who are post-MI, or patients that are having this this remodeling of the heart being done. So especially with CHF patients as well, this is really important because by blocking this process, you can help to stave off disease progression, worsening remodeling of the heart. So other activity, overactivity of the RAS system can help lead to hypertension, CHF, diabetic nephropathy, so especially with diabetics who are having high blood sugars and causing high pressure on the glomerulus kind of causes it to be kind of shredded. So you end up getting that diabetic nephropathy there, and then also myocardial remodeling. So you can see where ACE inhibitors are also going to be good not only for your post-MI patients, but also for your diabetic patients because they will be kidney protective. So this is going to be a very good thing for those patients. And so in general, you'll see that agents that affect the RAS system have very good effects on mortality and morbidity in these type of patients. So diabetics and cardiovascular disease are going to be the two big places that these will be working. So when we inhibit angiotensin converting enzyme, we're going to see decreased amount of Ang2 vasoconstriction because we have decreased amount of the actual Ang2 being produced. Ang1 isn't nearly as potent of a vasoconstrictor. You're going to see decreased renal vasoconstriction, decreased synthesis of aldosterone. You're going to have less sodium reabsorption. You have less increased release of norepinephrine being sent out to the sympathetic nervous system, less bradykinin metabolism. So really all these things you can see done are helping to decrease blood pressure, can decrease the pressure on the system, on the kidneys especially. And so one of the other things you're going to see here as well is you actually end up inhibiting that negative feedback loop. But even though your kidneys might be releasing more renin in response to this, you're still inhibiting that enzyme pretty thoroughly, so you don't really see much of an issue there.
For the renal vasoconstriction,
Mm-hmm.
decreasing that, is that for the efferent as well?
That's for the efferent as well, yeah, because you're decreasing that the amount of Ang2 that's being produced, and so not as much of it's there to vasoconstrict. And that's also why you have to be careful with patients who are having renal insufficiency that are really dependent on having that Ang2 vasoconstriction, because if you give them just a full dose of an ACE inhibitor right off the bat and all of a sudden you have a big dilation occurring in that efferent arteriole, you can decrease the pressure at the kidneys and cause an acute kidney injury that can occur due to that. So that's why they say, even though it's renal protective for especially diabetic patients, you want to kind of start low and go slow as you increase that, so you don't have such a dramatic effect on the kidneys. So our ACE inhibitors are going to have pretty much identical mechanisms of action and effects. The only big thing you're going to see is maybe some differences in their half-life and also metabolism, which will show you some tables to show that. Most of them are going to be prodrugs. You guys remember what a prodrug is?
Yeah.
What's that?
It's not active until it's metabolized.
Yeah, so it has to be metabolized. The original form is not active, so it has to be metabolized. So, for example, enalapril will get converted over to enalaprilat. So they add an AT to the end of that will denote the active form of it. So I'll show you those in just a second. And then the active form gets eliminated through the kidneys for the most part, except for fosinapril is one of the exceptions there. Will end up getting metabolized through the liver. So here are there's a couple of slides of these because there are a lot of ACE inhibitors out there. So some of the common ones you'll see will be like lisinopril, captopril. Enalapril is interesting because this is the one ACE inhibitor that has a IV form, and so it comes as enalaprilat as the IV form. So it's already active. So you just inject it into the vein, and all of a sudden it's working. Enalapril, it's one that has the IV form next to it. Then here's the next slide. So again, quinapril, ramipril, perindopril. Just know if there's a pril on the end of it, it's probably an ACE inhibitor. Okay, so again, the nice thing about ACE inhibitors as well is that most of them have once daily dosing, so they have pretty decent half-life. Captopril is kind of the shorter one. We may see end up being given twice a day. And notice that especially if you have a shorter acting agent, that it might start to lose some effectiveness towards the end of the day, which is why you might need to add on a second dose. So something like lisinopril is very frequently given just one time a day, but occasionally you may have to give it twice a day in order to get kind of full 24-hour coverage. You tend to see a pretty steep dose response at lower doses, and then that flattens out as the higher you get. So that basically what that means is that at lower doses, as you can gradually increase it, say going from 5 to 10 milligrams of lisinopril daily, you get a pretty big jump in your decrease in blood pressure, versus if you were to go, say, from 20 to 40, it starts to flatten out a little bit, so you don't really get as much bang for your buck. So eventually, even though you keep driving up your dose, you're not necessarily going to see as big of an increase in your antihypertensive effects. So again, big places you're going to see them being used. Hypertension, they're going to be good for decreasing total peripheral resistance, working both on systolic and diastolic blood pressure. They're good to decrease left ventricular hypertrophy, some of it's due to that remodeling, but also by relieving some of that elevated pressure there. And again, it's going to be preferred in diabetics because it is kidney protective. So again, it's going to help to stave off that diabetic nephropathy over a long period of time. It's not going to reverse anything, but it'll help to prevent it from getting worse for a longer period of time. So just kind of slow things down. Again, you'll see it frequently being recommended for CHF patients or those with left ventricular dysfunction. This is going to help to decrease that remodeling that occurs in that hypertrophy. You're going to end up having decreased afterload by decreasing that peripheral vascular resistance. You'll end up having decreased preload, increased cardiac output, and you'll have delayed progression of the CHF. So have you guys gone over CHF yet? Okay, so you know how do you stage the disease state? So basically, it's based on your symptomatology. So based on how much activity you can have before you start to have symptoms, and so basically it correlates to the actual functional decline in the heart activity. So by decreasing the amount of remodeling that's going on when you have someone with CHF, you can basically kind of prolong the amount of time it takes them to go to stage 2, to stage 3, to stage 4 as you go on down the road. So it's very important for that. It helps us to decrease incidence of MI or further hospitalizations, and basically anyone with left ventricular dysfunction should receive an ACE inhibitor unless they have some contraindication, which we'll talk about those in just a minute. So again, you can see here a lot of the processes that we kind of mentioned before, how all these things are kind of cyclical, how having heart failure means you have reduced cardiac output, which is going to lead to further sympathetic activity and vasoconstriction, because if you have decreased cardiac output, your blood vessels want to respond by clamping down in order to make sure everything kind of keeps its perfusion up. All of those things are going to lead to further cardiac remodeling, and which can also lead to increased renin release. So you can see how this thing is kind of cyclical and how it's all kind of feeding into one another. So by kind of inhibiting at that renin point, you can help to decrease a lot of that remodeling and hope to keep your cardiac function as good as you can for as long as you can. We'll also see ACE inhibitors being used in post-MI or myocardial infarction, because you can help to decrease that remodeling there, and you see an overall decrease in mortality when given post-MI. So it's another very important group of patients to receive these. We also mentioned the diabetic nephropathy. So by decreasing the glomerular pressure, you're going to decrease remodeling in the kidney as well. So again, it's going to help to prevent or delay the progression of renal disease. And then you can actually also see some decreased progression of renal disease in other nephropathies as well. So it's very frequent that you'll see kidney patients being on this in order to help kind of stave off further progression of their decline in kidney function. So as far as side effects go, you're going to see that dry cough is going to be one of the biggest side effects that you see with ACE inhibitors. ACE inhibitors are typically very, very well tolerated, but this dry cough is thought to be due to the fact that by inhibiting angiotensin converting enzyme, you increase amounts of bradykinin in the body, and so that's thought to lead to activating those cough receptors in the lungs. Usually it's going to be seen for anywhere between a week after starting therapy up to 6 months, and it's not necessarily related to dose or to agent. So some people are just more susceptible to it than others, particularly women happen to be a little bit more susceptible to it. And frequently, it's not going to lead to any kind of chronic ailments, but certainly can have a decrease in quality of life if you're coughing all the time. So you may need to convert over into another type of drug, which we'll talk about in just a little bit. Other big things you're going to see, and this is an important one, especially if you're giving this to patients who have poor kidney function, is hyperkalemia. So you're definitely going to see a pretty reliable increase in potassium levels when giving this to patients. You're going to see this more pronounced in patients who have renal disease. Those that are taking potassium-sparing diuretics. Do you guys remember any potassium-sparing diuretics? It's like triamterene. Thiazides are not potassium-sparing. Amiloride would be the other one. Loops are not. So again, there's a specific group of potassium-sparing diuretics, so it's important to know those. Also, the aldosterone antagonists would also do this as well, because again, these are working to decrease the amount of aldosterone being released. So you want to be careful in patients who are on potassium-sparing diuretics, and also those that are on potassium supplements. They need to be watched as well, because again, they can have pretty dangerous rises in potassium if you're not careful. You can also see, especially with your older patients who maybe don't have quite as much kind of physiologic reserve, you can see orthostatic hypotension with this. So especially with the first dose, or if you have an upwards titration in your dose. So very frequently you'll recommend giving it at nighttime, to where hopefully they will kind of sleep through that initial bout, and then eventually they'll kind of get more used to it over time. You're going to see this more in patients who are maybe sodium depleted, they have CHF, or on their multiple antihypertensives. This can be more pronounced as well. And then we mentioned the renal function impairment. Again, this is for patients who have renal disease whose renal blood flow is really highly dependent on angiotensin II. So if you give a big full therapeutic dose to one of these patients, you can have an acute drop in your GFR. Again, this can be reversible if you take the drug away, but just start with low doses and start to gently titrate up as the patient tolerates it. You guys know what GFR is, right? Yeah, there. Yep, glomerular filtration rate. So then other things that are a little bit good to know, but a little bit more rare, is angioedema. Does anyone know what angioedema is? Yeah. Yeah, so it's kind of an allergic reaction, but you get a big, massive swollen tongue. You have airway closure. It's distinct from anaphylaxis. It's treated a little bit differently, but essentially you're going to have this rapid swelling in the nose, throat, mouth. It can happen. It's kind of interesting because maybe like a third of your patients will have it occur within the first week. The next third of your patients may have it occur, say, within the first 6 months of therapy, and then after that you have another third of patients who may have it years down the road. So there's nothing to say that just because they've been on it for 2 years doesn't mean it couldn't happen to them. So if they have any increase in swelling, any kind of inspiratory wheeze or anything like that, they need to get checked out immediately. A lot of it is thought to be due to bradykinin buildup, so it's thought to be one of the reasons for that, which is why you see this more with the ACE inhibitors and some of the other classes we'll talk about. And then also, this is going to be contraindicated for pregnant patients, especially in the second and third trimester, since it can lead to some pretty significant birth defects and fetal death. Other thing you can see here as well is that NSAIDs can, as a drug interaction, NSAIDs can decrease the effects of ACE inhibitors, just because of the fact that if you have ACE inhibitors working to decrease that constriction on the efferent arteriole, your kidneys are going to respond by trying to open up the vasodilatory effects on the afferent arteriole, and by blocking that, you can see that you're going to have vasoconstriction on one end and vasodilation on the other end, and so you're going to have the kidneys kind of taking a hit in the middle. So if you had patients who cannot tolerate getting an ACE inhibitor, you have another group of drugs you can use that have very similar effects. So this will be our angiotensin receptor blockers, or ARBs. Again, the limiting factor of ACE inhibitors is that even though you're blocking the metabolism or blocking the effects of angiotensin converting enzyme, there's some alternate pathways for angiotensin II to be produced. So you can have things like chiamase or trypsin still producing it. And so what those angiotensin or angiotensin II specifically working on are these angiotensin receptors. You have two in particular, AT1 and 2. And you see the AT1 is expressed pretty widely throughout the body, so the heart, the endothelium, vascular smooth muscle, the kidneys. And the AT2 is going to be more primarily expressed during development. So limited use in the adults. You may see it more in the fetuses and whatnot. So AT1 is going to be the main receptor we're going to be focusing on for our ARBs.
So in other words, you use AT2 for children?
Well, they're just saying that you have a higher expression of AT2 receptors in fetuses, developing fetuses, than you do in adults. So it's mainly AT1 is the main receptor you see expressed in adults.
So is that why it's contraindicated in pregnancy?
Exactly, yeah. Because if you're monkeying around with angiotensin II, especially on those receptors, then yeah, that's where you see the effects. So again, just to show you, once the angiotensin 2 is made, it's going to be affecting those receptors. Again, angiotensin 1 receptor is the main one we're going to be focusing on. So our ARBs are going to be high affinity binding. They're slow dissociation, so they have really good sustained blockade of the AT1 receptors. So you're going to see very, very similar effects to what you saw with the ACE inhibitors. So decreased you're going to see vasodilation, renal vasodilation, decreased aldosterone, all the same good things we saw with the ACE inhibitors. When looking at a comparison between your ARBs and your ACE inhibitors, you're going to see the ARBs are better at reducing the effects of angiotensin 2 at the AT1 receptors. ARBs will indirectly activate AT2 receptors by increasing angiotensin 2 levels. So actually one of the things you'll end up seeing is that by blocking those receptors, your body kind of senses that and says, well, I need more angiotensin 2 around. So it kind of stimulates renal release to occur. So you end up getting some stimulation of AT2 receptors. Clinically, you don't know if that's really all that important, but it's something that does occur. The other big thing that you see is that ARBs don't inhibit the breakdown of bradykinin. This can be kind of a disadvantage as far as some of the antihypertensive effects go, but it's also going to be one of the big differentiators and why you might use an ARB if the bradykinin-induced cough is going to be an issue for your patient. ACE inhibitors, mainly going to be eliminated through the kidneys, but ARBs will be both through renal and the bile excretion. Doesn't necessarily get recycled. So just because something gets spit out into the bile does not necessarily mean it'll be reabsorbed, because it could have been metabolized to a point where it can't be reabsorbed back through the GI tract. Yep. Good question, though. So some of these are going to be pro-drugs. Some of them will be non-pro-drugs. I'm not going to ask you which ones are which on a test. I at least want you to be able to say which ones are ARBs versus an ACE inhibitor. So you see the sartan or the artin ending on there kind of denotes it's going to be an ARB. So candesartan, olmesartan, losartan. You see the pretty similar naming convention there. Places you'll see the ARBs being used mainly for hypertension. Again, you see very similar uses for this as the ACE inhibitors. You're going to see the addition of this in conjunction, or you see combination products with HCTZ, usually being a very common one. You guys remember what HCTZ is? Yeah, hydrochlorothiazide, which is what type of diuretic? It's in the name. It's a thiazide diuretic, yeah. So HCTZ is commonly combined with these drugs. You'll see a lot of combination antihypertensive products that are out there. So we'll kind of go over some of those a little bit later. You're going to see that typically for your patients, we kind of mentioned that thiazide diuretics are good antihypertensives for patients who are salt sensitive. ACE inhibitors and ARBs are not going to be quite as effective for those type of patients, so it's very frequent that you would see ARBs and thiazide diuretics being mixed because of that reason. So you can kind of get patients who are salt sensitive with the thiazide diuretic, and then you get additional benefits from adding on one of these angiotensin blocking drugs. You'll also see these drugs being used in patients with left ventricular dysfunction, so post-MI, CHF, and also for diabetic nephropathy prevention, mainly because these are going to have the same effects as you would see with the ACE inhibitors. They can be kind of used interchangeably for the most part. You'll still see hyperkalemia occurring with this. You'll still see hypotension happening here. Again, for patients who already have poor kidney function, you can see acute decreases in renal function you want to be aware of. And again, you do not want to give this in the second and third trimester of pregnancy. So again, anytime you're doing anything monkeying around with the cardiovascular system, especially in CHF, you want to start low doses and titrate up. Notice here that the ARBs do not cause cough, mainly because they're not really affecting bradykinin metabolism. So that's one of the big benefits there. I know my cousin personally had to switch over from an ACE inhibitor over to an ARB just because the cough was just so nagging. It was just just kind of interrupting. His wife was probably going to kill him before any of his heart problems did because the cough was so annoying. So just know that also angioedema has a much lower incidence in patients who are on ARBs. So there's a potential that you may switch a patient with an ACE inhibitor induced angioedema over to an ARB, and they will not have a cross-reactivity there. Because again, a lot of it is thought to be due to buildup of bradykinin, which you don't really have with the ARBs. Any questions on those? All right. Next, we'll talk about our calcium channel blockers. Yes?
Actually, for the angiotensin receptor blockers, you said that there's a T or AT1 and there's an AT2.
Mm-hmm.
do they affect both?
They're really only affecting AT1.
So, if they only affect the AT1, then why can't they be used during pregnancy if they don't affect the AT2?
Yeah, so good question. So again, all of it has to do with receptor specificity. And remember that just because something is more specific for one type of receptor does not mean that it's absolute, right? Especially when you consider that by changing dose, anything like that, you can end up losing more of that specificity, especially as it increases. So if you imagine, if you're giving to a pregnant patient, she has a normal amount of AT1 receptors, just like any adult does, but the fetus has, only AT2 receptors. So even though the ARB might be more specific for AT1, if there's nothing else for it to really affect, at a certain point, you're going to get some of those AT2 receptors being affected by the ARB, right? So just remember, selectivity is never an absolute thing. You're always going to see some degree of cross-reactivity between receptors. Yep, good question. Okay, moving on to our calcium channel blockers. So there's lots of different types of calcium channels that are found within the body. The main one that we're going to be talking about will be our L-type calcium channels. You're mainly going to find these in places like the sarcolemma within the vascular smooth muscle within the heart, and they're going to be really important for causing muscle contraction. So by blocking these calcium channels, you're going to see big decreases in the amount of smooth muscle and myocyte contraction that you can have. The three groups we'll talk about, we'll kind of be mentioning these as your dihydropyridines, and then your non-dihydropyridines. So this will include the benzodiazepines and also the phenylalkylamines. There's only one drug for each of those groups, so we'll just kind of call those the non-dihydropyridines, and then all the other ones are dihydropyridines. Okay, we'll talk about how those act a little bit differently within the body. So the L-type calcium channels are going to be primarily found on the vascular smooth muscle, on cardiac myocytes, and also on cardiac nodal tissue, specifically the sinoatrial node and the atrioventricular node. Okay, so we'll talk about the differences in the dihydropyridines versus the non-dihydropyridines. I don't know when my screen went out. Okay, it came back. We'll talk about the differences in how the dihydropyridines work versus the non-dihydropyridines, but it's important to make that distinction because you're going to see ones that are going to work primarily in the heart and some that are going to be working more primarily in the vasculature. So again, just a picture of cardiac physiology. I'm sure you guys have seen this before, but mainly the SA node, the AV node, those are your primary pacemaker cells within the heart. And so by blocking calcium channels with those, you can decrease the automaticity of that, right? So if I decrease automaticity, the heart rate's going to go down. I can decrease contractility as well. You can see here on your left side, you have your SA and AV nodes. Notice those are those kind of slow response cells, kind of those natural leaky type cells that allow sodium in. Notice here, if I can get my mouse to come up, that you have a big influx of calcium that occurs as soon as you hit that certain action potential point. And then, by decreasing the amount of calcium that can get into the heart, notice you're going to have a decreased peak there. So decreased contractility, decreased automaticity. On the flip side, if you're looking at your fast response cells or the non-pacemaker cells, again, you're going to see calcium being a big player here as well. Again, by blocking that, you're going to have less calcium influxing into the cell. And then you also know that calcium is, when calcium enters the myocytes, it's really important for that to interact with the sarcoplasmic reticulum that allows more calcium out into the cell, and that's what causes the contraction. So by blocking that initial influx of calcium, you can end up decreasing the basic contractility of the heart. Yes.
But it wouldn't stop the heart. It's just gonna not the force of it is just gonna.
If you gave enough of it, you could.
Oh. But you just want to soften up the force of it. Is where
essentially, yeah. Because if you're looking at things like myocardial oxygen demand, or if you're looking at you also see that some of these are going to be working as antiarrhythmics as well when we get to that section. But yeah, so decreasing the automaticity, so it won't be as fast, and then also you can decrease the contractility as well.
So does it elongate the action potential?
It won't let it be as strong because it's only really affecting the influx of calcium into the cells, not necessarily affecting the repolarization rate necessarily. Okay. Which is why you don't really see it affecting ventricular arrhythmias. You usually see them used for supraventricular arrhythmias because you're really more affecting that nodal tissue than anything.
So it's just there to be more specific to SA.
SA and the AV node, yeah. But we'll talk more about that when we get to the antiarrhythmic section. Okay, so here's another picture of how calcium channels within the myocytes leads to contraction. So you see here, these are those fast response cells. So again, you have your calcium channels here. Once the action potential comes along, it'll open up these L-type calcium channels, and this is going to allow the sarcoplasmic reticulum to be activated, and that more calcium is going to be released into the myocyte, which allows for the this contraction to occur here, right? And then eventually, when you're having recovery of the cell, more calcium is going back into the sarcoplasmic reticulum, and then you also have channels that will help to kind of reset the heart as far as getting calcium out of the cell, right? So that's basically what they're doing, is by just blocking that channel, you block how much calcium gets in, so not as much gets released from that sarcoplasmic reticulum. Thus, that contraction is not going to be as strong. Just another picture kind of showing the same thing, how less calcium in here is going to lead to less from the sarcoplasmic reticulum. That's the actin myocyte. It's not going to be contracting it together as hard. This is kind of a picture more depicting on what's happening with calcium channel blockers on the vascular smooth muscle. So if you can imagine the smooth muscle surrounding the blood vessels, again, calcium is coming in, releasing calcium from the sarcoplasmic reticulum, and that's what's causing vasoconstriction. So if you can inhibit that calcium influx, you're going to have vasodilation occur instead. And so those are the main antihypertensive effects we're going to see from that. So again, as far as the effects of calcium channel blockers on the veins, we see that CCBs, or calcium channel blockers at therapeutic doses, are basically ineffective at decreasing venous tone. They don't really have much effect on the veins, but what they can do, is because they have more effects on the arteries, is that you're going to see a decrease in the afterload, right? So a decrease in the amount of pressure the heart is pumping against, but you're not really going to have much of an effect at preload, at least as far as therapeutic doses go.
So would these be preferable in somebody with right-sided failure?
Potentially. There's some rare cases where you might want to. Typically, for patients with heart failure, you avoid calcium channel blockers like the plague because it's a cardiodepressant. But I think there might be some rare cases where you might use it for right-sided failure. Yeah. Might be something to look up. So looking at the calcium on the arterial blood vessels versus the myocytes. So again, here what we can see is that the myocardial cells depend on exogenous calcium to come in through those L-type channels, like we saw, to allow that internal recirculating pool of calcium to be released from the sarcoplasmic reticulum. So this is kind of just saying what we saw before. Whereas the arterial blood vessels really depend on that exogenous calcium as well. Typically what you see is that the arterial blood vessels are going to be more sensitive to the actions of the calcium channel blockers than the myocardial cells. So basically what we're going to see is that there's going to be kind of a divide between the non-dihydropyridines and the dihydropyridines, whereas the dihydropyridines are going to work much, much more on the blood vessels and not really a whole lot of direct cardiodepressant effects, versus the non-dihydropyridines are going to work specifically on the heart and just a little bit more on the blood vessels.
So the non-dihydro would be the myocardial cells.
Yeah, they're working better on the SA and the AV node specifically. So we'll talk about what those are in a second. So again, dependent on looking at the non-DHPs, again, these are going to be reducing both slow inward current and decreasing that rate of recovery. So this can help to lead to slowed AV conduction. So you have a little bit of a slowed rate of recovery there. And then with the dihydropyridines, or the DHPs, is going to reduce the slow inward current. Doesn't really affect much on the nodal tissue, but it's definitely going to work more on the blood vessels. So just know that dihydropyridines are working primarily on the blood vessels, or dihydropyridines are, and the non-dihydropyridines are more primarily working on the heart. So uses where we'll see our calcium channel blockers being used are going to include angina, hypertension, certain arrhythmias, primarily the supraventricular type. You can see with diastolic heart failure potentially, so as you kind of mentioned there, and then some rare cases where things like cerebral ischemia and the migraine prophylaxis as well. So lots of kind of myriad uses for your calcium channel blockers. So here's a good table that will help you kind of divide up the effects of the calcium channel blocker. So if you look here, your non-dihydropyridines include diltiazem and verapamil. Those are the only two non-dihydropyridines. You're going to see that they have okay effects on vasodilation, but primarily are going to be suppressing automaticity in the AV and the SA nodes. Whereas your dihydropyridines, which I'll show you a list of those in a second, are going to work primarily on vasodilation and will have very negligible effects on the automaticity in the cardiac cells. Everyone got that difference down? Okay. So again, we're going to look at diltiazem first as our benzodiazepine. Again, you don't just need to know that it's a non-dihydropyridine. I'm not going to ask you the chemical name on there. So this one's good. It's available both IV and PO. This is very frequently used to help control supraventricular arrhythmias, AFib, things like that. In the short term, if we give it via IV infusion, you can see it used for angina, hypertension, supraventricular tachycardias. Big things to note with this is that it's a primary metabolite through 3A4, and it actually will also inhibit CYP3A4. So this is going to be huge for drug interactions. You're going to see similar effects with verapamil. So this is a big deal. Note that has a fairly short half-life, which is why when you give it IV, you have to give it by continuous infusion versus a lot of the oral products are going to be extended release products. So you can take that less frequently throughout the day. Lots of side effects associated with the calcium channel blockers, which is typically why they're not going to be first line for management of hypertension. Some things you can see include due to the vasodilation, you can have flushing, you can have headache, hypotension, peripheral edema you can see there. And then with the, especially with the non-dihydropyridines, with the negative inotropic effects, you're going to have things like first degree AV block, bradycardia being potential, and then you can have exacerbation of their congestive heart failure. As far as adverse GI effects go, constipation is probably going to be one of the bigger ones to focus on with the calcium channel blockers, so just be aware of that. If you imagine, it's, if it's affecting smooth muscle, it's doing that in the GI tract as well, so you can imagine slowing that down to cause constipation. You can certainly see some CNS effects, but this is going to be more related to kind of decreased perfusion, especially in older patients who have kind of poor hemodynamic reserve, so you can see things like drowsiness, dizziness, depression in some cases. Rarely you can see some gynecomastia or some sexual dysfunction in certain patients, and then potentially you can see gingival hyperplasia, which is kind of a rare one.
Do they work on the smooth muscle in the lungs for people with asthma?
Not really. You don't really see any kind of bronchodilatory effects, so it's not quite specific for that. Certainly you can see other things that kind of non-intuitively work to decrease some of the vasoconstriction going on in the lungs. Like if you look at some of your erectile dysfunction meds like sildenafil, like those are also used for pulmonary hypertension because it can actually help to release and relax some of that smooth muscle in the lungs. We'll talk about those later. So contraindications to receiving diltiazem, if you had advanced heart block, if you already have hypotension, and then some relative contraindications would be things like heart failure, liver disease, GERD, it can worsen that. Again, if you imagine, GERD is an issue usually of having that esophageal sphincter not really being tight enough. If you imagine this being a smooth muscle relaxer, again, that's kind of opening up a little bit, can make that worse. So just be aware of that interaction there. So again, drug interactions are going to be huge for this drug, and especially with verapamil as well. So I just want to mention this here that as a CYP3A4 inhibitor, it's going to be affecting things like atorvastatin, simvastatin, so all of our anti-lipemics we already talked about. You can also do some other drugs like certain anti-epileptics like carbamazepine, propranolol. Really the big things to take away here is that it's not only is it a CYP inhibitor, but it's also a substrate of CYP3A4. So it can also be affected by that by other 3A4 inhibitors as well. So atazanavir is a fairly common HIV medication that works by inhibiting CYP3A4. So this can actually increase levels of diltiazem, right? So not only does it inhibit the enzyme itself, but it's also a substrate, so other drugs can cause it to have levels increased by inhibiting it. That make sense?
So the HIV drugs would increase the levels of
that? Yep. Exactly. So again, drugs that can affect diltiazem. So I already mentioned that atazanavir, but things like ritonavir and tenofovir, those are also other HIV medications. We'll probably talk about it at a later time. And then just other drugs that can affect the pharmacodynamics of diltiazem, so other cardiodepressants, other antihypertensives. You can see some synergistic effects from that standpoint. The counterpart to diltiazem, and again, you can kind of think of these two drugs as pretty much synonymous in your mind, is going to be verapamil. Again, this is one is available IV or PO, can be used for very similar indications as you would see with diltiazem. Again, it's also available in sustained release preparations orally, so you can have longer durations of action there. Again, looking at the effects here, you see maybe a little bit more vasodilation, so this might be a little bit better as an antihypertensive, and very similar effects in regards to suppressing automaticity in the SA and the AV node. Big things to note from this slide are just that this is also a CYP3A4 inhibitor and also a substrate of CYP3A4. Here you can also see some interactivity with CYP2C9, but clinically these don't pop up nearly as often as the CYP3A4 inhibitions do. Note here, very similar side effects to what you see with your diltiazem. Constipation is actually going to be more pronounced with this drug than you see with diltiazem, so just be aware of that. Again, very similar side effects across the board other than that. Yes?
Does it counteract the function of the drug if they take something for constipation?
Well, it depends on what they take for constipation, I guess. So if you were to use like a stool softener, probably not, right? Probably wouldn't really affect that. Clinically, there's not really any interactions that would decrease the effectiveness of one of these drugs that would be used for the constipation. Yeah, good question though. Again, similar contraindications to what we saw with diltiazem as well. Just note, very similar drug interactions, so not only is it a substrate for CYP3A4, but it's also an inhibitor of 3A4, so you're going to see the same type of drug interactions here. We talked about the PGP protein before, right? It's a P-glycoprotein we mentioned. It's a drug efflux pump that is used in the GI tract to kind of kick drugs out to prevent them from being absorbed. Again, very similar activity here, so by inhibiting PGP, you can see increased levels of the drug because more of it will be absorbed into the systemic circulation. Again, very similar side effects here, or drug interactions you can see with this drug. Okay, so the next group is going to be the dihydropyridines. So some ones you'll see fairly commonly include things like amlodipine, nifedipine. Nicardipine is interesting because it's one of the few that are available IV. These are mainly going to be seen used to treat things like angina and hypertension. Notice you're not going to see these drugs being used to treat supraventricular arrhythmias because these are not going to work at all on the nodal tissue. These are primarily going to be for the vasodilatory effects on the vasculature. Other ones you can include things like nisoldipine, isradipine, felodipine. Don't get so hung up on the indications here. Just know that these as a class are going to work very similarly to one another. Nimodipine is actually kind of interesting. We see this used in patients who have had a subarachnoid hemorrhage because you can actually give this to them to help prevent vasospasm in the CNS after a hemorrhage has occurred. That's one kind of a unique one. Typically, because these drugs are so potent on causing effects on the vasculature and causing hypotension, you kind of want to avoid short-acting formulations because you can see big drops in their blood pressure and it comes kind of rebounding right back up. So typically, you'll either use an extended release preparation or you'll have drugs that just have longer half-lives. And here, just note, vasodilation is a primary activity of these drugs. So as far as metabolism goes, note that these are metabolized by CYP3A4, so they're substrates for it, but they do not inhibit CYP3A4. So you're not going to see the same drug interactions. Certainly something like a grapefruit juice could inhibit the metabolism of this. Certainly something like a phenytoin could do that, but these will not cause an increase in levels of other drugs like you would see with verapamil or diltiazem, right? Here's just a quick example, just to kind of show you the kind of various pharmacokinetics of these drugs. Just note that the half-lives can change pretty widely depending on the drug you're looking at, whereas something like nifedipine is kind of a poor drug to give as a short-acting agent because you see kind of a very short half-life here, very short duration of action, versus something like amlodipine, which is a very good once-daily drug that you can get away with because the half-life is so much longer. So just know there's a big variability between your dihydropyridines. So as you might imagine with the side effects with these drugs, it's going to be more focused on the vasodilation here. Because they're so much more potent, you're also going to see worsened peripheral edema, especially for patients who have peripheral vascular disease, patients who have CHF, things like that. Again, you can end up seeing gynecomastia being worse with nifedipine. This is kind of the worst drug for that. And again, very similar side effects other than that. You just don't really see the same kind of cardiodepressant effects. So no AV block, no bradycardia really you see with these drugs. And in fact, if anything, some of the things you actually get is a reflex tachycardia with the dihydropyridines, because when you cause a vasodilation, what's the heart want to do to compensate for that?
Pump harder.
It wants to pump harder, wants to get the cardiac output up, so you can actually see tachycardia in response to these drugs. So it's actually one of the things we'll look at. So if I have a patient who, say, has overdosed on an unknown cardiac agent, they just say, hey, they take something for their blood pressure, we don't know what it is, you can actually look at their vital signs and have some kind of idea of what they might have taken. So if they come in and they are tachycardic to 140 and they're hypotensive, that leads me to think, oh, it might have been a calcium channel blocker like a dihydropyridine versus something like a diltiazem, which is going to cause them to be bradycardic and hypotensive. So taking clues like that can kind of help you to know what they potentially could have been exposed to.
So with the peripheral vasodilation, will that work? Will that affect the distal capillaries? capillary beds. So for people like CHF, if this exacerbated.
So you can see like flushing and things for sure.
Right.
But yeah, you typically like CHF, you can see worsened edema that can happen there. Yeah. So some patients you would not want to give this to, potentially with severe aortic stenosis would be one group, and then potentially if they have unstable angina or recent MI, especially with immediate release formulations, you can actually cause a very big drop in their blood pressure, which could lead to worsened ischemia on the heart. So again, just know that you're going to see mainly pharmacodynamic interactions with these drugs. So again, if they are on other drugs, they're going to drop their blood pressure. This is going to have a synergistic effect with that. You're not necessarily going to see the same, you don't really see synergistic cardiodepressant effects because again, they're not really going to be working directly on the heart as much. And just know that other CYP3A4 inhibitors can affect the metabolism of these drugs to increase your levels. So again, they're not going to be inhibiting CYP3A4 themselves, but they will be affected by other CYP3A4 inhibitors. Yes?
So, if all these drugs affect things like HIV drugs, what do HIV patients take if they have hypertension?
They take a lot of stuff. I'll tell you what. So yeah, so there's certainly some drugs that they won't have any interactions with. So we looked at our ACE inhibitors, like those don't cause any CYP interactions, so those could be good agents for them. A lot of beta blockers would be okay for them. So again, it's one of those things where if you have an HIV patient who, you know, they could be on a pretty complicated drug regimen, you just have to run your interaction report beforehand to make sure you're not going to give them something that's going to throw them off. Because not only could you see interactions with the HIV meds increasing the levels of these other drugs, leading to toxicity, but you can also end up having issues where they can lead to toxicity from the HIV meds if you inhibit their metabolism. So just be aware, you know, it's one of those things that's kind of a sticky situation. We'll probably talk about HIV later on at some point in the course. Okay, I'll give you guys a break right now, and then we'll come back and continue on with our antihypertensive. Okay, the next group of drugs we're going to talk about are going to be our beta blockers. So we know that these are going to work as competitive inhibitors. At the primarily, we're going to see their effects on the beta-1 receptors, particularly on the heart. So by affecting these, by blocking, you know, the normal substances that are activating beta receptors, which what do you think those are? What are like normal ligands for the beta receptors in the heart? Like the normal things that are binding them. Yeah, epinephrine, norepinephrine, dopamine, all those things. So by blocking that, we're going to end up seeing decreases in cardiac output. Acutely, you can see an increase in total peripheral resistance as your blood vessels try to kind of acclimate to that. And you can also see some impaired exercise tolerance, right? Because if you're blocking those beta receptors and I say, you know, go run a mile, your body's going to respond by saying, hey, you pick up the heart rate and spit more norepinephrine on your heart, but it's not going to be able to respond as well. So that's one of the big side effects you're going to be seeing with these beta blockers. You can also see competitive blockade of the beta-1 receptors that mediate renin release. So if you're blocking renin release, you can also see decreases amounts of angiotensin 2 being out there, which will also decrease your hypertension. And then what you'll also see in the lungs, especially if you're dealing with non-selective beta blockers, is you can have competitive blockade of the pulmonary beta-2 receptors. And so by blocking those, you can end up seeing increase in bronchial smooth muscle constriction, which can potentially be problematic in patients with asthma or reactive airway disease. Some other things you can see, especially in your non-selective beta blockers, are going to be blocking the presynaptic beta-2 receptors, which will also lead to decreased norepinephrine release. And then you can also see some other effects in the CNS as well. And so we'll talk about some of the lipophilicity of some of these beta blockers. Some are very lipid soluble and have a very easy time getting up in the CNS, in which case you can see things like CNS depression. You see migraines that can develop from this. You can also end up seeing some altered baroreceptor reflex response. So you can end up having some issues with orthostatic hypotension that can develop from this.
I thought beta blockers were used to help treat migraines.
So it's interesting you should say that. We'll talk about that. So you have a cause of migraine. Yeah, because you can also see that with calcium channel blockers as well. Some of them can be used for migraine prophylaxis, yet they cause migraines, right? So some of the things that they think are related to migraines are due to vasospasm or to vasodilation that can occur. So the idea is if you were to give one of these acute antihypertensives that causes vasodilation, you can open up the blood vessels and cause a headache, right? The idea is if you have kind of a resting a small amount on the system at all times and kind of preventing any other things from coming along causing an acute vasodilation, you can hopefully prevent the migraine from occurring. There's not like a super lot of good hard science behind it, but that's kind of the running theory. you have a question?
In terms of CNS effects, you say an effect is depression in terms of the feeling or CNS depression?
More like CNS depression. Potentially you could see it's like worsening actual like depression, the actual psychiatric condition, but mostly it's gonna be more like mental status depression. Yep. So some of the differences in beta blockers that we'll talk about, one includes selectivity. That means selectivity specifically for the beta-1 receptor. So you're going to find that some of them are going to be non-selective and will affect beta-1 and beta-2 receptors somewhat equally. You're going to see some that are more selective for beta-1 receptors. And those are going to be important to make that distinction between them. We'll see that some are going to be metabolized through the liver, some will be sent through the kidneys. We won't get too hung up on that because clinically we don't run into too many issues where we have to do dose adjustments and whatnot. And then some of them you can actually see will end up having some degree of this, what we call ISI or intrinsic sympathomimetic activity. Basically what this is that some of them can have kind of a partial agonist effect. Clinically it doesn't come up all that too often, but it's thought to lead to some issues where you can see some degree of side effects, like things like seizures for some drugs, some asthma exacerbations, and whatnot. Just know that some of these drugs will have it, but clinically it's not really going to pop up too frequently. Some of them can have membrane stabilizing effect, which is going to be important when we talk about the effects on the heart. So some of them can actually have enhanced antiarrhythmic activity by kind of stabilizing the myocardium and preventing reentrant rhythm from coming through and causing an arrhythmia. We'll talk about some ones that have that specifically. And then you can actually have some third generation beta blockers. So, if you're talking about generations of beta blockers, the first generation are really the non-selective ones. Your second generation could be considered your beta 1 selective agents. And then here we actually have a few that are going to be third generation that have kind of a grab bag of miscellaneous effects that we'll talk more about when we get to the specific agents. But just know that these can be additional benefits they can have, like blocking alpha 1 receptors can help with hypertension, and NO production can help with causing vasodilation as well. So we'll talk about those in just a little bit. So the first that we'll talk about are going to be the non-selective beta blockers. In general, the way that people remember this naming convention is that N through Z are going to be your non-selective beta blockers, and then A through M will be your selective beta blockers. But you got to know the exceptions to that rule when we get to them. Okay, but in general, N through Z will be your non-selective agents. Again, these are going to be affecting both beta 1 and beta 2 receptors to pretty much the same degree. Note here that propranolol has very high lipid solubility. This is important because this is one of the ones you want to avoid in elderly patients because this can cause some mental status changes for them and it can be kind of problematic. You can't tell if grandpa's having worsened dementia or is it propranolol that's causing mental status changes. So it should be propranolol. Yeah, that's also another one that we see very frequently being used for prevention of like stage fright and used for anxiety because again it is lipid soluble, so given the CNS can help block some of those kind of fight or flight type of responses. Oh, I saw a light bulb go off. That's what I teach for. Sotalol, which is actually misspelled there, should be SOTA-lol. That's going to be important because that actually has some specific antiarrhythmic activity that we'll talk about when we get to the antiarrhythmic section.
Which one was that?
Sotalol. The selective or beta 1 selective beta blockers are included again like your acebutolol, atenolol, bisoprolol. Esmolol is an interesting one because it is IV only. It's actually a very good short-acting IV antihypertensive that we'll use sometimes in the ER. You can also see metoprolol. Just so you know, the RE and the HM just refer to renal elimination or hepatic metabolism, so just be aware of that. Notice here that most of these are going to be more on the water-soluble side, so you don't really see as much of the CNS effects with these guys. And then the third generation, these are the important ones to kind of keep separated in your mind. If you're looking at things like cardiolol and betaxolol, we already talked about that when we talked about glaucoma. The two ones you may see more for systemic use for hypertension include carvedilol or Coreg. This is going to be important because this has some additional effects like alpha-1 blockade, which what does alpha-1 receptors do on the vasculature? Yeah, they constrict. So by blocking that, you can actually have vasodilation that can occur, causing decreased blood pressure. They can also have some antioxidant, antiproliferative effects. That'll be important when we talk about CHF and which beta blockers you can use there. And then labetalol is also another good IV agent you can use for blood pressure management. It can block alpha-1 receptors. It can also actually activate beta-2 receptors. And if you remember, in the lungs, beta-2 receptors cause bronchial smooth muscle relaxation, but on beta-2 receptors in the vasculature as well can cause vasodilation. So you can get some very good kind of synergistic effects from these receptors. So indications, very frequently you will see beta blockers being used for hypertension. Typically not recommended as first line for hypertension. Usually it's going to be more of your ACE inhibitors or your thiazide diuretics. You may see this working a little bit better in younger patients, especially those that maybe have kind of an increased amount of catecholamines. If they have pheochromocytoma or something, or if they have like resting tachycardia, this could be better. But remember, commonly a complaint is going to be fatigue and limited exercise tolerance, which may be kind of problematic for your younger patients. But again, you can still use them in elderly patients as well, just probably not as a first-line agent. So looking at the effects that we're going to see, because again, acutely we mentioned that you can have an acute drop in cardiac output. That doesn't really explain how you have kind of prolonged decreases in blood pressure with these agents. So again, if we're looking at this, we have the map on top here. What's the map stand for? Yeah, it's your mean arterial pressure. So it's basically a ratio of your systolic and diastolic to give you kind of an average blood pressure. You guys know how to calculate MAP? Used to? It's actually 1/3 of your systolic blood pressure plus 2/3 of your diastolic blood pressure. Because essentially you're in 1/3 systole and then 2/3 of the time you're in diastole. So that's kind of how you measure that. Usually your monitors will just tell you automatically, so that's kind of nice. And then you'll have your CO, which is your cardiac output, and then your TPR, or total peripheral resistance. And again, the left side of the graph is going to be more the acute use of a beta blocker, and then the right side is going to be more chronic use of the beta blocker. So acutely, what we can see is that you can have a decrease in total peripheral resistance. Decrease in cardiac output, which will lead to a compensatory increase in total peripheral resistance, right? So what does that do for your MAP? Not much, right? Well, you can see right there, it doesn't really do much to it. It kind of balances itself out to some degree, right? So what you see though with more chronic use, because you're doing things like decreasing Ang2, you're decreasing norepinephrine release and also the sympathetic nervous system activity, and by eventually altering that baroreceptor reflex, you're going to see more sustained decreases in your MAP. You're going to have kind of a sustained decrease in your cardiac output, and again your total peripheral resistance will eventually kind of go down as well. So that's where you kind of see more of the sustained antihypertensive effects, even though initially it seems kind of odd because your body's trying to compensate for that decrease in cardiac output. That make sense? Okay. We can also use these for glaucoma, as we kind of mentioned previously, so I won't belabor that point. Again, migraine prophylaxis, we mentioned, you said astutely, like that doesn't make sense. Why would you, it causes migraines, why would you use this to prevent it? Again, some people will get worse when they're on these beta blockers, but typically you try to use low doses to help prevent the kind of that vascular hyperresponsiveness that you see in some of those migraine patients. You can actually use beta blockers occasionally in hyperthyroidism, or if you're having thyroid toxicosis, so especially like thyroid storm. You can use this to decrease some of the sympathetic nervous system effects like the tachycardia, the tremor, and the anxiety. But also, interestingly enough, something like propranolol can actually inhibit the conversion of T4 to the more active form of T3, which is your thyroid hormone. So propranolol can help to inhibit the conversion of T4 to T3, and T3 is your more active form of the thyroid hormone. You can also use beta blockers for angina, which we'll talk about more in just a little bit. So again, if you're having symptoms of ischemia, a lot of it is related to having too much myocardial oxygen demand versus not enough supply. So if you can decrease cardiac output and decrease the amount of work the heart is doing, you can help to kind of allow for more blood flow to get to those ischemic areas. So that can be useful there. So we'll talk more about that in a little bit. And it can also basically just raise, like we said with younger patients, you can have exercise intolerance, but actually for a patient with angina, by kind of inhibiting that increase in cardiac output when you're doing activity, you can actually increase their exercise tolerance time. So just think about that in your type of patient and how you're dealing, what kind of cardiac physiology they're dealing with. You can have use these for acute myocardial infarction. You probably want to avoid the ones with intrinsic sympathogenic activity because you don't want to actually activate those receptors. But what this actually does is help protect the ischemic myocardium from the effects of norepinephrine and epinephrine by blocking those receptors. And then you can actually end up seeing it protect against recurrent MI and decrease mortality. So we'll see where these are actually going to be good agents to prevent mortality post-MI. And then because these are also working on the nodal tissue in the heart, you're going to see these also being used for supraventricular tachycardia, so AFib, PSVT, PVCs, they can all be used for that. Occasionally you can use this for acute panic attacks, so like, always take mine right before I come in here because you guys are very intimidating, as you know. So again, this is decreasing a lot of the sympathetic nervous system effects. You see decreased tremor, sweating, all of that. So I know, personally, when I was in pharmacy school, I had a couple of people in the class that were, they were either on Xanax or they were on propranolol in order to help decrease a lot of the public speaking anxiety they would get from that. So hopefully they got over that at some point. But that was definitely a common medication to use in pharm school. I'm sure lots of Adderall too, but I don't know. And then also, you can have to decrease the amount of tremor that's going on because the beta-2 receptors that are on the skeletal muscle. So obviously for that, you'd want to use more of a non-selective beta blocker since the selective ones won't really affect the beta-2 receptors. So just a few beta blockers can be used for CHF. This is an important list to remember because normally if you think about CHF being decreased ejection fraction, decreased cardiac output, you wouldn't want to give something that is a cardiodepressant on there, just like you don't want to give them a non-dihydropyridine. But what they've actually found is that by using low dose beta blockers that you gently titrate up in these patients, you can actually see improved effects for them and decreased mortality. So upwards of like a decrease in rate of 40 to 50% over 3 years. So these are very important drugs, and it's only carvedilol, metoprolol, and bisoprolol that are on this list currently. And again, normally you wouldn't want to decrease your cardiac output, but if you look at these patients, they have impaired left ventricular function. So by kind of slowing down the heart a little bit, you actually allow the ventricle to kind of fill a little bit better. It's able to have a little bit more kind of a controlled squeeze, and that has actually improved effects for their overall kind of health. Initially you can see some decrease in symptoms or an increase in symptoms for them, but that's why you kind of start these drugs, in hospital to where you can actually watch them, monitor them, and then slowly titrate the dose up as they can tolerate it. Yes?
So would this secondarily help with edema, peripheral edema?
Potentially, if their whole functional status is improving and they can be more active and they're walking around and can kind of work off a lot of that fluid, potentially they can help with the edema. But it's not going to be working like something like a loop diuretic would, that specifically gets them to expel more fluid. Yep. But obviously, if you're just sitting around, you kind of have a lot of pooling in the venous system, that can worsen the edema. But if they're up and moving around, being active, that can help. So adverse effects, again, bronchoconstriction is more of a concern with the non-selective beta blockers. It can lead to worsened asthma exacerbation. A third of COPD patients have some degree of bronchospasm associated with that, so they might want to avoid that one. You're relatively safe using a beta-1 selective agent. Again, remember that selectivity is all relative, so some patients might be more sensitive to it than others. But in general, you can get away with using a beta-1 selective beta blocker for asthmatic patients. Again, be careful if patients have CHF because, again, that can worsen the negative inotropy, especially if you're starting at kind of full dose therapeutic doses. If they already have bradycardia, this can worsen that, so you can see AV block for sure that can develop. You can also see some increase in their glucose. So this can be problematic for your diabetic patients. So in kind of different reasons for type 1 and type 2 diabetics. So for type 1 diabetic, one of the things that you can see is that typically when you have decreased glucose in the bloodstream, your body is going to respond by upping epinephrine that's going to work on the liver to cause glycogenolysis to occur, which allows gluconeogenesis to take place, right? So that increases the amount of glucose in the blood. Beta blockers can actually inhibit that by blocking beta receptors on the liver, so it inhibits that glycogenolysis, so you can actually end up prolonging the time that they're hypoglycemic for. And not only that, but like we said, for the anxiety issues, beta blockers kind of block that sympathetic nervous system activation. So same thing here, you're masking those responses. You're not getting sweaty, you're not having the tremor, you're not having those issues, so you can end up masking symptoms of hypoglycemia. You might not notice it for some time. For the type 2 diabetics, on the other hand, they're having issues with actually having decreased insulin release, which will lead to increased amounts of glucose within the bloodstream. Also, if those patients get hypoglycemic, this can also mask the signs. You can see issues for certain patients. They can have impaired peripheral circulation. So typically by blocking the beta-2 receptors in the blood vessels, those are normally vasodilatory in nature. By blocking that, you can cause actually some vasoconstriction potentially, which can worsen things like Raynaud's. You can have kind of cold extremities. You can see skeletal muscle fatigue, and then potentially some worsening of peripheral artery disease. And then also when you have chronic use of beta blockers, you never want to have an acute withdrawal of the drug because frequently if you're blocking all those beta receptors, your receptors start to upregulate or downregulate in response. They upregulate and you have more beta receptors, and if I were to take away that drug all of a sudden, now that norepinephrine that I'm releasing can affect way more receptors, and you can see kind of an increase in cardiac effects. So you can see angina, MI, marked increase in blood pressure. So again, use a slow withdrawal in order to help prevent that. Again, the high CNS solubility, you can see CNS depression. You can see nightmares, vivid dreams, hallucinations that can occur, fatigue. So again, just keep in mind that the more lipid-soluble agents you use, the worse that's going to be. Propranolol is kind of the poster child for that, though. And then you can also see some elevated triglycerides, which may be problematic. As far as drug interactions go, you're primarily going to see more pharmacodynamic interactions. So, if you mix this with a calcium channel blocker like a non-dihydropyridine, they're both going to have cardiodepressant effects, which can lead to some issues there. If you were to add on to another drug called clonidine, which we'll talk about in a little bit, both of those can lead to big decreases in blood pressure and also some withdrawal effects we'll see as we talk about it a little bit. So, any questions on beta blockers? Okey-dokey. Moving on, we're going to next talk about some vascular smooth muscle relaxants and alpha blockers. So first off, we have some drugs that are alpha-1 adrenergic antagonists. So we already said that alpha-1 receptors do what in the vasculature? They constrict. So if we block those receptors, we're going to cause vasodilation and hypotension. So we actually have some drugs that can do that. So if you block those receptors, decrease in total peripheral resistance, potentially get that reflex increase in heart rate like we saw with the dihydropyridine calcium channel blockers. So just be aware of those kind of cardiac effects you can see there. A couple ones we have include prazosin. Again, these are agents that are not going to be used very frequently. These are typically agents we're going to be adding on as probably third or fourth line agents, or if they have contraindications to receiving, a beta blocker, or ACE inhibitor, or calcium channel blocker. Like these are kind of later agents, but it's important to let you guys know about them now, so that way you can at least be aware of their actions if you see a patient who's on them. Again, biggest effects you're going to see with the alpha-1 blockers are going to be orthostatic hypotension, especially in your older patients that have poor cardiovascular reserve, and postural dizziness can be associated with that as well. Again, we mentioned that mild reflex tachycardia that can occur there. Again, a lot of it is related to causing a decrease in TPR. You're going to end up having a reflex increase in your cardiac output, which can, you can see that over time. Typically, it can be blocked by, if you have like a beta blocker on board as well, it can kind of balance that out. But just be aware of that. And then you're also going to have a lot of those reflex mechanisms we mentioned back in the diuretics, like increased renin, increased sodium and water retention, which will limit kind of the maximal effects you get out of these guys, which is why you don't really use them by themselves. And then also by blocking the alpha receptors, you can end up seeing impotence at a pretty high rate in men as well. Just like a lot of other antihypertensive NSAIDs can attenuate the response of these drugs by affecting blood flow at the kidneys. Adding on other vasorelaxants or other cardiodepressants can worsen the postural hypotension. And just be aware these patients have cardiac or renal failure. This can potentially worsen those by doing that vasodilation. So some other ones that fall in the similar category that work very, very similar would be terazosin and doxazosin. So you can kind of think of all these alpha blockers very similarly as together. Again, they're going to be used, these guys can actually be used either as an antihypertensive. They can also be used for benign prostatic hyperplasia. Do you guys know what that is? Not necessarily prostate cancer yet. It's in a large prostate. What's the problem with that? Yeah, it kind of squeezes down in the ureter, so you're going to have decreased urine outflow. So that is actually regulated by some alpha-1 receptors as well. There's some specific subtypes we'll talk about. But by having too much alpha constriction on that, you can squeeze down on the prostate, and by blocking it with these drugs, you can actually have that relaxed a little bit and can help with urine outflow. Tamsulosin or Flomax is a very specific alpha-1 antagonist. It actually works at the alpha-1A receptor, and this is actually the one that is specifically expressed on the prostate. So this is going to be much more specific for that, which limits the amount of vasodilation that you get to some degree. Certainly if you increase the dose enough, you're going to see hypotension and dizziness. But because this is much more specific, this is a much better agent for BPH than you see with some of the older alpha-1 blockers. We mentioned the third generation beta blockers having some mixed actions here. You can see that labetalol and carvedilol both have the ability to block some of the alpha-1 effects. So again, that can be additive to their antihypertensive effects. So just be aware that that's there. Notice these are kind of minor parts of its activity. If you were to compare the labetalol, the beta blocking effects compared to alpha effects, 5 to 10 times to 1. So it's a minor effect, but it's still there, can still be useful. Okay, the next group of drugs we'll talk about are going to be our central sympatholytics. So you had to imagine by that name, what do these drugs do? Yep, inhibits the sympathetic nervous system. Good. So again, by stimulating postsynaptic alpha-2 receptors, and also by possibly working through these imidazoline receptors, you can centrally cut off the amount of norepinephrine and epinephrine being released by the sympathetic nervous system. So this is kind of working on hypertension from kind of the top down by decreasing the amount being released from the CNS. So this could be working a couple of different sites in the brain, but just know that by activating these receptors, you're decreasing sympathetic nerve activity. So you imagine here, clonidine is going to be one of our main agents we see here. By decreasing the amount of sympathetic nervous system activity, it's going to go have kind of a trickle-down effect to decrease not only that of the heart's activity, so you have decreased cardiac output, but it's also going to work on the vascular smooth muscle to lead to hypotension as well. Yes?
Is this drug used for like short-term?
It can be, but more frequently you see it used for more long-term use.
Couldn't that be dangerous?
So it can be if you were to use, say, like if you're a child that got into it, or if you were on a very big dose, but typically these are fairly well-tolerated agents for the most part.
I mean, like in the sense if you did need to respond in sort of sympathetic nervous.
Yeah, so it doesn't like completely cut you off, right? Because otherwise you wouldn't have probably had no blood pressure at that point, right? So you still will have some activity. It's just cutting it down to a degree where you're having kind of a safe drop in your blood pressure. And these are pretty potent agents, like a dose of clonidine for an adult is like 0.1 milligrams. So you're not giving very much, and so you're going to see kind of a modest drop in your blood pressure and your heart rate, but you're not going to see like them bottoming out necessarily, unless they're on other drugs that were interacting or something like that. I've seen frequently, because this also, clonidine comes as a patch as well for kind of long-term action, and so I've seen cases where kids will get into it, they'll ingest a patch and can have huge doses being released over a course of several days, and they get very, very sick from this.
Piggybacking on Christine, so like if the person were on this and they went to the
Might be too big for her to do that.
What's that?
It might be too big for her to do that.
Oh.
Just kidding. Not literal piggybacking. Anywho.
So if a patient, we're on this medication and went to the ER and needed epi,
Mm.
would the epi still work?
It could still work, because if you imagine, this isn't really doing anything to the receptors on the actual blood vessels of the heart, so it can still affect that. It's just decreasing the amount that's coming out from the CNS.
Oh, okay.
So epi would certainly still work. And does anyone know where you might see clonidine being more frequently used nowadays? Not seizures, but... ADHD is actually going to be a big place you're going to see it being used more frequently now, especially in kids. So again, you're going to see when you give these central sympatholytics, you're going to see decrease in total peripheral resistance, decrease in heart rate, and also decrease in cardiac output. So some of the advantages of this is that, unlike a dihydropyridine or something where you get that reflex increase in cardiac output, this is actually going to have a much more balanced effect on both the heart and the vasculature. It's useful if it's, independent of age, race, or gender. You can use it potentially for monotherapy. can work well in the elderly, but due to the fact that there's not a whole lot of mortality benefits with this drug, you don't really get any kidney protective effects from it. You're going to see a lot of the other drugs being used more first line, generally due to patients having other compelling indications for the drugs. So they have diabetes, or if they have heart failure, whatever it happens to be. So in general, because we're working up in the CNS, you're going to be seeing drowsiness and sedation being a very common side effect. You can see sexual dysfunction. These typically has a very narrow therapeutic index. So again, even small changes in dose can lead to big changes in blood pressure and cardiac output. So just be aware of that. That's why kids are so sensitive to it. And then you also have that abrupt withdrawal syndrome. So by blocking release of those catecholamines, you're going to upregulate those receptors. If you have an abrupt withdrawal, you can see big increases in blood pressure and heart rate. So clonidine is probably going to be the poster child for the sympatholytics. Again, it's an alpha-2A agonist, so it's going to be also activating the imidazoline receptors as well. Acutely, you can actually see a small increase in blood pressure because similar to what we saw with like our Afrins or oxymetazoline that works locally at the nose, even though that one's an alpha-2 receptor agonist, you can still activate some of those alpha-1 receptors and cause vasoconstriction. Same thing can happen with clonidine. You may see an acute increase in blood pressure, but it's pretty short-lived. And eventually, you're going to see you're going to have a decrease in blood pressure and heart rate. Can see increases in blood glucose, mainly due to inhibiting insulin secretion, so just be aware of that as well. You can also see some decreases in AVP. That's also known as ADH or antidiuretic hormones, so just be aware of that. Cause some sodium retention. So this, again, it's another drug that's frequently given with diuretics to help kind of prevent that. And this sedation is actually going to be one of the biggest effects you're going to see clinically commonly. Interesting thing, you can also see some analgesic activity. So this is useful both in the surgery setting. Sometimes for certain surgical procedures, you can actually give an anesthetic along with a small dose of clonidine in the epidural space, and that can actually lead to decreased use of opioids for pain management and post-op. You can also give clonidine to help with things like opioid withdrawal. So frequently, if we have babies who come in with neonatal abstinence syndrome, moms are abusing drugs during pregnancy, and now they are coming into the NICU, and now they're withdrawing from those drugs. You can actually give clonidine to help decrease a lot of that sympathetic outflow that's happening there. Because again, they're withdrawing from it just like the mom would, so they're really cranky and they're not sleeping well, and their vital signs are all over the place. By giving this, you help kind of calm them down quite a bit, and kind of help ease the withdrawal process. Unfortunately, it happens way more commonly than you would expect. So again, additional side effects of withdrawal reactions we already mentioned, impotence, orthostatic hypotension. This is very, very similar to all the other antihypertensives we've kind of looked at already. Another one you're going to commonly see being used is going to be guanfacine. Again, this is going to be a little less potent than clonidine, a little bit more selective for the alpha-2 receptors. You see less sedation, maybe occasionally withdrawal syndrome, but this one I also frequently see being used for ADHD as well. So typically you'll see kids on, say a stimulant in the morning like an amphetamine, and then on the evenings they'll put them on one of these drugs that kind of help calm them down in the evening time. So a very frequent combination of drugs we'll see some kids on. Okay, then moving on, we have our direct vasodilators. So direct vasodilators are going to be working directly on the arteries to cause dilation and decrease total peripheral resistance. Again, these are going to be kind of last line agents you might be seeing being used for hypertension because they cause a very significant reflex sympathetic activation. So big increase in heart rate, increases in cardiac output, fluid retention, and really these end up leading to a lot of tachyphylaxis. Have we talked about tachyphylaxis before? Tachyphylaxis is a process in which have you guys heard of the term with tolerance before to drugs, right? So usually, as I take a drug, I'll eventually get tolerant to the effects. But if I increase that drug dose, I can continue to get more effects. It's just I have to keep increasing the dose to retain the original effect, right? So just like you see like heroin abusers, they have to keep increasing their dose in order to keep getting high, right? Kind of a different process that can occur is called tachyphylaxis, where basically even if I keep increasing my dose, I see no increase in effect. Right, this can happen with like nitroglycerin. We'll talk about that later, how that can be a problem. But just realize that just because you're increasing your dose doesn't necessarily mean you're going to be seeing increase in antihypertensive effects because you have so many of these reflex mechanisms happening here. Right, so these are kind of poor antihypertensives, but they're older agents you might still see being used very somewhat infrequently. So here's a couple we'll talk about as we go through. Just kind of note that some of the differences in, if they are having bigger effects on the arteries, on the arterioles, you're going to be seeing more tachycardia associated with them, and that's more sodium and water retention. So you're going to be seeing that more often with minoxidil, and then also this other drug called diazoxide. Does anyone know the brand name for minoxidil? Yeah, it's Rogaine. So you can apply that topically, and you actually see some hair growth from that one. That's actually, and originally it was an antihypertensive. They saw this adverse effect of hair growth. So, for chronic hypertension, you may get some use out of it with combination with like a diuretic or a beta blocker. Frequently, you may see hydralazine being used. I more commonly see hydralazine being used for acute bouts of hypertension. You can use it as an IV agent. And then potentially minoxidil could be used as an antihypertensive as well. Infrequently, especially if you're having like a hypertensive crisis, for patients you can use IV agents like nitroprusside, diazoxide, or phenoldiazepam to actually cause some vasodilation to decrease the hypertension immediately. Hydralazine is probably the more common one you're going to see in this group. Do you guys remember any antihistamines that sound very similar to this drug? What is that? Nope. It's called hydroxyzine. Hydroxyzine, otherwise known as Atarax. It's a very similar name to hydralazine, right? So you know it. You just speak up. So it's a very, very similar name. This is a very common look-alike, sound-alike drug that can get mixed up. And so if I were trying to give someone who is having allergies hydralazine, also bottom out their blood pressure, bad news, right? So be aware of those look-alike, sound-alike drugs because they are big sources for error. This one we're not quite sure what the actual mechanism here, but it increases cyclic GMP, which will increase our nitric oxide pathway. We'll talk more about that when we get to our nitrates a little bit later. But just know that it is able to cause some very good vasodilation. We'll look at some complicated slides here, but just know that this is when you're vascular endothelial cells. Just note that hydralazine is going to be more working on things like blocking the effects of calcium to some degree, working through nitric oxide, which is this pathway down here. We see that nitric oxide helps to increase levels of cyclic GMP, which is a vasodilatory agent in the vascular smooth muscle. So the interesting thing about hydralazine is that it undergoes this hepatic metabolism called acetylation. And so when looking at the population, you're going to see some people who are fast acetylators and some people who are slow acetylators. So the slow acetylators, what do you think happens to the drug levels in their body? Yeah, it should go up, right? You should accumulate the drug over time because you're not metabolizing quite as fast. The fast acetylators, though, their levels are going to go down more quickly because they're metabolizing more fast or more quickly. So, as you might imagine, who might be more likely to have treatment failure for treatment of hypertension? Well, just looking at if they're a fast or slow acetylator. Yeah, they're fast, right? Because they're metabolizing all the drug out. So if you see someone who's not responding very well, it could be because of that. Versus someone who has very dramatic responses, could be more of a slow acetylator. Certainly, you're going to see the same reflex mechanisms we saw previously. And the big side effect you want to note with this one is that you can actually have this lupus-like rash that can develop related to people who are slow acetylators, building up levels of hydralazine. So lupus normally has that kind of butterfly-like rash across the face. You can see the very same thing here. We also mentioned this. I'm not sure I mentioned this drug or not. Did we talk about TB treatment? Yeah. Yeah. Yeah, so isoniazid is another one that for slow acetylators can cause that lupus-like rash. So just know that those two drugs can cause a very similar side effect. So again, if you're on higher doses for longer term, typically women tend to be more slow acetylators, and then also Caucasians tend to be more slow acetylators. So again, a lot of these drugs are typically going to be contraindicated, especially if you have significant ischemia, coronary artery disease, just because they're so potent at causing vasodilation that you can lead to kind of cardiac hypoperfusion and ischemia. And also note that this will turn your stools black. So again, if you normally see black stools, what are you thinking? Pepto-Bismol or bleed. Yeah, I think upper GI bleed. So you want to let your patients know that, hey, this could be changing your stool color. Just be aware of it. The next one's going to be minoxidil. This one's actually going to be working to activate these ATP-modulated potassium channels. So it'll let potassium out of the cells, causes it to hyperpolarize, and prevents the smooth muscle from contracting. So again, this is going to be typically working up here on these potassium channels right here. So again, minoxidil used to be was originally studied for as an antihypertensive, but once we saw that it had really significant issues with myocardial ischemia and causing arrhythmia, and then we saw that the fact that it causes abnormal hair growth, we said, hey, let's just use this stuff topically and we'll just market it as that. Now, I will tell you that minoxidil does not like to go into solution very well, and so a lot of the Rogaine products have a high alcohol content. And so one time we actually had a patient who had ingested a whole bottle of minoxidil because he was an alcoholic that ran out of his supply. So went to Walgreens, found this minoxidil, and just drained it. I've never seen anyone so hypotensive in my life. He had to be on at least 5 or 6 different pressors just to maintain some sort of perfusion for at least 4 or 5 days he was on it before we started to wean him off anything.
So because he ran out of alcohol,
Yep.
he drank Rogaine.
Yeah, because he found the first thing that had a high alcohol content. It's like 10% by volume or something. Yeah, addiction's kind of nasty.
Rogaine's expensive.
Well, if you're in the Walgreens just chugging bottles, then it's not so expensive.
Yeah, we had a patient do that.
Yeah, just
Checked his levels like 2 hours later.
Yeah.
And they were double.
Yep.
And security forgot to check his bag, and
Mhm.
he drank an entire liter of this drink.
Yeah, so I mean, alcoholics will drink lots of weird stuff, isopropyl alcohol, all kinds of stuff. Yep. Okay, so again, minoxidil, we know it causes hypertrichosis or this hair growth, so it can occur. If you take the drug systemically, you can see it on the face, back, arms, legs, but just applying it locally on the skin, you can see it just at that site. You can actually see some cardiovascular effects if you were to apply a large body area with the Rogaine, but again, it's pretty rare to see clinically. But this is another big one. If kids get into it, it can be very, very, very bad. Nitroprusside is a good agent that we use IV for management of hypertensive crises. This one's interesting because it actually contains some nitric oxide particles, which are useful as vasodilators, but it actually includes 5 cyanide molecules as well. So, if you ever want to poison your patient, this is a good way to do it, right? Now, your body normally makes some amount of cyanide anyway in just normal physiologic processes, so this is not normal for the body to encounter. You have pathways to metabolize it, but in some cases you may have patients who you're giving such a high dose to or they have poor liver function, you can actually end up having this build up and cause some toxicity. So again, they can have trembling, vomiting, convulsions, acidosis that can occur, and so we can actually combat this by giving it with another drug called sodium thiosulfate that actually helps to donate sulfur molecules to the liver to allow it to process the cyanide a little bit better. And then if you have a patient with renal toxicity, they can actually build up the byproduct called thiocyanate, which will lead to all kinds of toxicity itself. So end of the line is, if your patient has poor liver function, kidney function, this might not be a great drug for them. Phenoldiprem is another good antihypertensive drug. This one works as a dopamine agonist that helps to stimulate cyclic AMP within the kidneys. This is good for renal, natriuretic, and diuretic properties as well, so you can kind of get rid of some fluid. You don't see this one being used too frequently, but every once in a while you might see it being used to kind of help manage this blood pressure. Again, dysrhythmia, as you can see with this one. And you typically use for very short-term management of severe hypertension until you can kind of get them switched over to something like usually an oral agent. So how do we treat hypertension? I gave you a whole lot of drugs there. Which ones do you use? I don't know. Yeah, there's a whole bunch you can use. Well, luckily we have guidelines that kind of help us out. So we have the JNC 8, which is your major hypertension guidelines. The last one was in 2014. Generally, you're going to see that your goal is to have your blood pressure less than 140/90. That's going to include your patients with diabetes and also chronic kidney disease. We know are at big risk for cardiac problems. What their recommendations were as far as medications to use is that in the black population, if they have or have not diabetes, you should start treatment with either a thiazide diuretic or a calcium channel blocker. Typically like a non-dihydropyridine, with a dihydropyridine, so like an amlodipine or something like that would be your best bet. Typically those are going to be your more salt-sensitive patients, and so they're going to respond a little bit better to thiazides and your calcium channel blockers. In the non-black population, with or without diabetes, you can start thiazide diuretics, calcium channel blockers, ACE inhibitors, ARBs. It's really going to be dependent on what their other disease states are and what else they should be on when we talk about CHF or MI or things like that. And then in chronic kidney disease patients, it says CKD, they should really be on an ARB or an ACE inhibitor. And again, that's because those drugs are going to be nephroprotective for them, right? Typically, if the goal is not achieved within 1 month, you can either increase the dose of your drug or actually add on a drug from another class. Keep in mind, you typically don't want to use an ARB and an ACE inhibitor at the same time. You want to use something from two different types of classes of drugs, right? So if I start off on a thiazide and it's not really kicking in after a month, then maybe I add on an ACE inhibitor or add on a beta blocker, right? That's generally the way it goes. Hopefully you don't have to add on a third agent, but in rare circumstances you might need to. Okay, questions on that? All right, moving on. Another couple minutes here. Talk about angina. Fortunately, we've already talked about most of these drugs, so I don't have to even cover half of this, right? Perfect. So we know ischemic heart disease, IHD, this is going to be this imbalance between myocardial O2 supply and demand. Basically, the supply is outstripping, or I'm sorry, the demand's outstripping the supply, and you're having signs of ischemia in the cardiac tissue. A lot of this is going to be manifestations of coronary heart disease. Most of it's going to be related to this atherosclerotic narrowing of coronary arteries. So certainly you can have acute coronary syndromes, which we'll talk about. We'll talk about unstable angina, acute MI. You have sudden cardiac death, and then we'll also mention now the chronic stable angina we'll talk about here. And we just know angina is going to be the manifestation of myocardial ischemia. It's going to be chest pain. So this picture did not turn out quite as well as I'd hoped, but essentially what you can see here is that for the oxygen availability, one, we're going to be looking at what our supply is, and so that's going to include basically the arterial hemoglobin concentration of oxygen, the coronary flow and distribution, which is going to be the one taking the hit in most of our CHD patients, and then looking at the actual cardiac extraction of O2 from there. Okay. On the requirement side, we're going to be seeing that wall tension, heart rate, and also contractility are going to be the main things affecting how much oxygen your heart is needing. Okay, so we're going to see that some drugs are going to work on availability, some drugs are going to be working on supply, or the actual demand of the heart, some drugs are going to be working on both. So it'll be important to remember which ones work on which type of side of the equation. So again, we know that we said heart rate, contractility, and this wall tension are all going to be affecting the amount of oxygen demand by the heart. Again, this is going to be a function, the wall tension itself is a function of preload and afterload, so a good thing we're talking about this already. Preload is that initial stretching of the cardiac myocytes prior to contraction. A lot of it's related to the ventricular and diastolic volume, right? So we're talking about some drugs that can affect preload are more affecting things like dilating the veins to allow them to hold more volume so you don't have as much going back to the heart. The afterload is a pressure that the heart has to pump against, and so this is more going to be related to the systemic vascular resistance. Again, when you're looking at the actual supply of oxygen getting to the heart, again, we can see that as you're having the atherosclerosis starting up, you get these big plaques that will eventually, can cause almost 100% blockage of a lot of these arteries. Actually, my father-in-law just recently had to have a second stent placed just because he was having a little bit of chest pain, didn't think it was too bad. His wife made him go to the hospital and eventually found 100% blockage in one of his coronary arteries. So he's doing fine now, but it's very timely to talk about this right now and all these drugs that he's going to have to be on. So again, angina is going to be this latent manifestation of ischemia, can occur with any degree of stenosis. A lot of it has not only to do with the actual narrowing of the vessel, but also the amount of vasospasm that's occurring as well. We'll talk about one kind specifically where you may not have any kind of narrowing whatsoever, where that's important. Typically, you can see it if you have 50% of your left main being included, or say 75% of any of the other major arteries being blocked. And then stenosis is defined as having greater than 90% blockage or virtually no flow whatsoever through that artery. The kind that I was talking about where it doesn't require necessarily any kind of narrowing is this Prinzmetal or variant angina, or otherwise known as vasospastic angina. This typically you can see happening to younger patients where they can have an issue with autonomic control where the sympathetic nervous system kind of clamp down on those coronary arteries, and even though it seems like they're having the symptoms of angina, it's really not related to the ability to supply the heart. It's just that they're so clamped down that they can't really get the blood to where it needs to be. Some cases it can be so severe you can see ST segment elevation, although it's probably less common for most cases, and will typically occur more during the night and the early morning hours. So we'll talk about how you treat that a little bit differently than normal angina. So certainly there's risk factors for developing angina. So if you have, non-modifiable ones that are, family history or your age, obviously guys are going to be more prone to this at younger ages. And then the modifiable ones, some things like sedentary lifestyle, diabetes, tobacco consumption. Those are things you kind of want to work with your patients to help reduce their risk of cardiovascular disease. So when we're treating angina, the big things we want to do is to increase the quantity of life. So if we can prevent an acute coronary syndrome, that sounds like a good thing to do. And then increase their quality of life. So very frequently you're going to have inhibition of their activities of daily living. They're going to have symptoms as they're exerting themselves, and so you want to help to relieve symptoms and hopefully prevent them from occurring in the first place. So some treatment strategies we can use include decreasing the myocardial O2 demand. So we can do that by decreasing heart rate, decreasing contractility, and then also by decreasing that wall tension. So by either decreasing afterload or preload, that can help to reduce that ventricular tension. You can also increase myocardial O2 supply. So by improving coronary blood flow, by dilating those vessels to allow more oxygen-rich blood to flow through, that's going to help as well. And then we're also going to look at things like stabilizing those plaques to help prevent an acute coronary syndrome from occurring. Certain drugs that can help with that. And then obviously you want to modify reversible risk factors, but a lot of people don't do that. So we have to give them drugs, right? You can always do your reversible risk factors if you can. Now treatment, obviously the best thing to do would be to reestablish flow through the vessels, right? So that's what my father-in-law went through. He had a percutaneous coronary intervention where they went through and used a balloon to kind of expand the vessel to try to get rid of that plaque, and they put a stent in. You guys know what a stent is? So basically kind of I don't know I think he had a bare metal stent placed. He's not really medical, so he's not really sure. But basically had a stent put in, just a nice metal mesh that keeps the vessel open. So he had that placed in order to prevent restenosis.
Why would you choose a bare metal over a drug-eluting stent?
It depends on. So a drug-eluting stent is typically embedded with a certain type of drug. I'm trying to remember the ones that it comes with.
I think she said they were chemo drugs.
Yeah, they're chemo drugs because they're immunosuppressants. Because ideally, anytime you're putting a foreign body into the blood vessels, your body's going to try to attack it, right? So typically, you have to put them on lots of antiplatelet agents in order to help prevent blood clots from occurring on there. But the idea is by inhibiting any kind of immune response, you can hopefully prevent any kind of blockage from occurring. I'm not well read on the data to say what the actual benefits are. I know, and I honestly don't know what percentage of people get bare metal versus drug-eluting stents, to be sure. Yeah. I should probably read up on that. So again, certainly you get PCI, but you could also have coronary artery bypass grafts where they actually take veins from the legs and stick them onto the heart. Has anyone ever seen open heart surgery before? It is so cool. They killed the guy and then they brought him back to life with new blood vessels on his heart. It's crazy. It's awesome. If you get a chance to check it out, do it. So again, when we're looking at pharmacotherapy, obviously it's a little less invasive, but we'll see some anti-anginals. So this is where we're going to see our beta blockers, calcium channel blockers, and there are nitrates, which would be the new group of drugs we haven't talked about before. And then we'll also look at some of our vascular protective agents. So this will be like some of our antiplatelet drugs, statins, and our ACE inhibitors. And obviously lifestyle changes need to be done as well. So the pharmacology overview, we want to decrease heart rate, contractility, and systolic wall tension. The drugs that are going to do that include our calcium channel blockers, our nitrates, and our beta blockers. Things that are going to help to increase coronary blood flow are going to include our calcium channel blockers, our nitrates, and then some of our antiplatelet agents like aspirin and clopidogrel. We'll talk more about the antiplatelet agents a little bit later. Now, as far as anti-anginals go, these are going to work to improve exercise capacity, reduce exercise-induced ST segment changes, and help to decrease the frequency of symptoms. So like we mentioned, this is where we're going to see our beta blockers, calcium channel blockers, both you can see dihydropyridine and non-dihydropyridine being used, and then also our nitrates, which are the new group of drugs. So again, just looking at grades of angina, you can see a lot of it has to do with the degree of symptoms based on exertion. So you can have different classes at it, but ideally we'd like to give them drugs to help prevent a lot of these symptoms from occurring and help to increase their exercise tolerance. So first thing we'll look at are going to be the beta blockers. Since we just talked about these, this will be pretty easy. Again, looking at what they're going to do on the demand side is that they're going to decrease heart rate, contractility, and that wall tension. But they're really not going to do a whole lot on the actual oxygen supply because they don't really cause any direct coronary artery vasodilation. So typically you're going to see beta blockers being recommended as first line in the absence of any other contraindications. They're also going to be really useful for patients who have, other compelling indications to be on beta blockers. So if they have pre-existing heart failure or post-MI and we're putting them on beta blockers to help prevent mortality, this is another good reason for them to be on this in the first place. Typically, you're going to be using your beta-1 selective agents, or you could potentially use a non-selective agent, but if you have an asthma patient or something like that, beta-1 selective is going to be better for them. And you could also potentially use a third-generation agent like carvedilol or labetalol. So really, any of them can be working because they're all going to be doing the same effects on the heart. Again, we know our contraindications. We kind of already talked about this, so I won't belabor these points. And we talked about the side effects as well. Again, which ones are more likely to cause nightmares? Which beta blockers in particular? Yeah, so your lipid-soluble ones, right? The ones getting the CNS. So propranolol being one of the big ones there. Good. Okay, next we'll look at our calcium channel blockers. I should be able to get through this last section here. So calcium channel blockers, both the DHP and the non-DHP, right? So which one is going to have a better effect to dropping heart rate? Should be your non-dihydropyridines, right? And those are which drugs? Those other two, you're right. Verapamil and diltiazem were the two in that category. So again, they're going to be better on decreasing heart rate and contractility and also working on wall tension, but you're going to be seeing that the calcium channel blockers, the dihydropyridines, if anything, they may have a slight increase in heart rate, but they're going to have more effects on decreasing that wall tension by affecting preload and afterload, right? So again, on the supply side, you may see some mild dilation in areas of stenosis, and you can also have relief of vasospasm. So you're more likely to use dihydropyridine for someone with that vasospastic angina. And again, just to break down the details a little bit more, again, we said diltiazem or verapamil are going to be better specifically for decreasing the contractility of the heart and decreasing the heart rate, whereas your dihydropyridines are going to have kind of neutral effects on the conduction. So you can use the non-dihydropyridines as initial therapy for reduction of symptoms if the patient was not able to be put on a beta blocker. Or if you were already on a beta blocker and did not have complete control of symptoms, you could add on a dihydropyridine. You don't want to do a non-dihydropyridine and a beta blocker at the same time because they can have really synergistic effects on depressing cardiac activity, right? And you can also use them with long-acting nitrates, which we'll talk about probably next time. So the population that we're going to be seeing this used in is contraindications. If they have contraindications of beta blockers, if they have vasospastic angina, this is a good one for them. Asthma, uncontrolled diabetes, and then if they have left ventricular dysfunction, you want to avoid your non-dihydropyridines because you don't want to depress that function further, right? So again, just know that DHPs are going to be a combination of beta blockers, non-dihydropyridines by themselves. Again, we already said the contraindications here. Remember, which ones have the significant 3A4 interactions? Non-dihydropyridine, so verapamil, diltiazem, again, they're going to inhibit 3A4. They're going to lead to increased levels of any other drug that's metabolized by that. It can also be affected by other 3A4 inhibitors. Good. Again, we talked about the adverse reactions here, so you guys know that. And then we will end here, and then we'll continue talking about nitrates next time. Any questions before I let you guys go? No? All right, I'll see you then.